You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by Pam Grubbs, clinical nurse specialist and assistant professor in nursing at Mayo Clinic College of Medicine and Sciences in Rochester, Minnesota, to discuss radioactive targeted therapies, safety, and common misconceptions. Thanks for joining me today, Pam.
Yes, nice to be joining again to talk about my favorite subject.
Wonderful. Well, to start us off, tell us, what is radioactive targeted therapy and how is it used to treat cancer?
Okay, so this is a type of treatment. It could have a protein that targets cells, and that protein is attached to a radioactive material, and then it travels through the bloodstream and attaches to the target. And then once it gets to the target, which is the cancer cell, the radiation then kills the cancer cells.
What are some of the radionucleotides and the cancer types that they target?
So the radionuclides can be attached to something to guide them to the type of cancer it's being treated. So, for example, lutetium-177, which the brand name is Lutathera, they attach the lutetium-177 to octreotide, and then the octreotide is injected and it is used to treat neuroendocrine tumors. Another one would be Xofigo, which is used to treat prostate cancer. And that one, the injection of the Xofigo, so the radium-223 dichloride, it binds with the minerals in the bones for metastatic prostate cancer. And then that radiation and treatment is delivered directly to the bone mets. And then another one I'd like to discuss is I-131. So that's sodium iodide. It is used to treat hyperthyroidism or thyroid cancer in this case, which is what we want to focus on. And the iodine is radioactive that is given. It's given by either a pill form or a liquid. And then the uptake happens within the thyroid cancer cells and the regular thyroid cells. So that's how it treats the cancer that way.
Great. What are common side effects associated with radioactive targeted therapies?
So lutetium-177, which the brand name is Lutathera, the common side effects that we see are nausea and vomiting, usually caused by the amino acids that are given during this treatment, because the infusion itself is 4 hours long and it protects the kidneys from any damage from the Lutathera. We also see diarrhea with these patients, but the patient usually has diarrhea as part of their neuroendocrine disease diagnosis. Also, as far as Lutathera hitting any blood count, the platelets and the creatinine are going to be something that the providers are going to want to follow and make sure that they go ahead and protect, like I said, the creatinine, especially since we know that the Lutathera can affect the kidneys. And then in rare instances, we might see carcinoid crisis in these patients, and this might be a side effect you see. That includes sudden changes in blood pressure, an increase in heart rate, wheezing and difficulty breathing, flushing, and hyperthermia. The treatment for the carcinoid crisis with the patient is the administration of octreotide. And that med has been staple, actually, for these patients. The neuroendocrine patients usually take short-acting and long-acting octreotide to treat their symptoms. But we make them go off that for a whole month before they get Lutathera to make sure that the Lutathera works as effectively as it can. So the octreotide is kind of like a rescue med in this case. Xofigo, for instance, has nausea, vomiting, diarrhea, swelling in the feet or the legs. But the main one that you might see with Xofigo is it hits the red blood cells, white blood cells, and platelets. So the practitioner is going to have to really follow those lab values on that patient. And then lastly, I-131, the only side effect that you might see that might be associated with this might be a little bit of stomach upset, because remember, this is PO. This is either a liquid or a pill form. And then, of course, the precautions with that, as far as, taking care of that patient, is all the precautions that come with anything that's radioactive. For this patient, it's that you stay 10 feet away from them for 24 hours and then 3 feet away from them for 5 days, and that you are very careful with any excretion that they have, whether it's urine, stool, saliva, that kind of thing.
So we were just talking a little bit about the precautions that you might have with these patients. Are these treatments done in the hospital, or are they done on an outpatient basis? And are there other safety concerns for both the patients and the nurses?
Wherever is starting these treatments, for instance, lutetium-177, the Lutathera, that can be given either in inpatient setting, which is where I work. We use inpatient beds for that. Or it can be given outpatient, since it's truly an outpatient therapy. However, you need to have certain precautions, like this patient needs their own bathroom, because that is where most of the contamination or the risk is going to be happening. It comes out in the urine. So it depends truly on what you're giving. I-131 is one of the drugs that it can be given safely as outpatient med, as long as the dose is not too high. Once it becomes a certain dose, then that patient has to become an inpatient, and then they can go home with certain precautions.
Okay. You recorded a webinar on radioactive targeted therapies in February. Since then, have there been any updates on side effects, administration, or anything else?
I think the only updates, I've got a couple of them actually. The only update I can think of is that I've been contacted a lot about how it looks at where I work and how it's set up and what does that look like. In an outpatient setting, an inpatient, what do we have to do? Who did we need to talk to in order to get that practice started? But I think that the side effects as far as what we're seeing, for instance, from Lutathera, it's rare, but we have been seeing pericardial effusions and chest pain in the patients that not only have the neuroendocrine tumor diagnosis, but they also have carcinoid disease of the heart also in their history. So that side effect was also noted in the studies, but I don't think, according to all of the studies I've read since it became FDA approved, I don't think we've seen it since it was FDA approved.
What do nurses need to be aware of when administering radioactive medications or caring for patients after they've received the treatment?
So the Health Physics Society, which is, they write the regulations and other consultations around radiation safety, they always tell us that it's nationally, internationally followed. ALARA is the recommendation, and it's ALARA, and it stands for as low as reasonably achievable. So basically, they want everybody to spend as little time as you need to get your work done. Don't be in around this patient for hours on end. Be very careful with their excretion. Just take normal precautions as far as wearing gloves when dealing with any of their excretions. Our nurses already know that we want them to limit the time because we want to keep them safe also. But that is everybody. That's the ALARA recommendation, goes for everybody who's involved, whether it's nuclear med, nursing, radiology, no matter who.
Okay, great. Thanks. How much radiation is the average oncology nurse exposed to, and how is this monitored to ensure that they are safe?
So that goes according to what institution you work at. Where I am, we consult radiation safety a great deal. If we have a question or a concern, they go ahead and address it, and they go ahead and say, yes, we'd be happy to go ahead and give you body badges to go ahead and monitor that. And then that is handed in quarterly to our radiation safety colleagues. They go ahead and they get the readings, then they give them back to that nurse so they know exactly how much exposure they've had. Nationally, when we look at the regulations, it says that you are not considered a radiation worker until you hit 5,000 milligrams. The most that we've seen as far as when I look at our levels for the nurses when I speak with them has been between 10 and 20. So again, it's way lower than what would be an at-risk dosage. We also have ring badges, and I see those being worn by the people who are actually administering the Lutathera. To use that as an example. So when they're giving it, they're right there. So the ring badge and the body badge they would be having. As far as regular dosage, what we see, I had that in my webinar back in February when I spoke, and I gave some examples. So when we're talking 10 to 20 milligrams, okay, that's just a random number from my practice. When I look at medical imaging, for example, a mammogram is about that much. A head CT is 200 milligrams, if you've ever had one of those. A full body CT is 1,000. If you look at everyday radiation exposure, which is something that we looked at for our nurses' education and getting them comfortable taking care of these patients, we looked at everyday radiation exposure. To live in Minnesota or Iowa, your daily radiation exposure, just by living here, just by being outside, is 45 milligrams. So again, we're like, we're exposed to radiation and we don't even know it. Let's see, I got a wristwatch in there, a smoke detector, airport screening. Flights are about 2.5 milligrams. Smoking falls in there. There's so many things that fall into giving us radiation that we don't know. So I think in the big scheme of things, it's a very small dose that you have potential to be exposed to.
Wow, those are some really interesting points and interesting numbers for oncology nurses to know, and also even the public and our patients in knowing how much radiation they're exposed to just on a daily basis, interacting in life, beyond what they are going to see with these treatments if you're caring for the patient. So just a little bit more on that. And when we were talking about, if they would go home, or are there certain things that you teach the caregivers about this, or is that exposure no longer an issue once the patients do go home? And what are the safety kind of things that you teach patients, their families, and the caregivers?
So depending on what the patient got for a radiation treatment, the precautions go according to that. So for instance, I-131, as I said, they are told, we would like you to stay away from the patient for 10 feet away for 24 hours. Well, that's not a problem, because if they get that high of a dose, they're inpatient with us, and they're in a lead-lined room. So we take away that, and then 3 feet away for 5 days, and then it goes down from there. We tell them, we've got a whole booklet of education that we give them. And again, that is based on all the recommendations from Radiation Safety and the Health Physics Society. We've got in there things like, we don't want you to share a bed with another person for so many days. We do not want you to have intercourse for so many days without a condom or some kind of protection. We don't want you to have, share a bathroom for a certain amount of time. If they have to fly home, because we have a lot of patients that have to fly home, we say as long as that flight is not over 24 hours, you're safe to be that close to someone else. But then when you get home, again, you have to go back to the distancing that we've recommended. We ask them if anything of theirs gets contaminated, that they bag it up and it sits for several weeks. If anything gets contaminated at the hospital, like when they're with us, and they have brought in, for instance, their cell phone, and it has gotten contaminated with radiation, then it stays with us, and it goes into a safe area where it can decay for 70 to 80 days, and then they can have it back. So again, there's so many things that we tell them. We actually made them a booklet, and it addresses everything that they might ask us. What if I have to drive home to Montana, with my loved one? Can we do that? I share a home with somebody. Can we do that? How about eating? It truly is. It's the all-encompassing booklet. And I think most facilities that do this type of treatment have something that they give the patient, and they give it to them before that treatment's even done, because we have to know if these precautions can even be followed before we give them the radiation.
That's a lot. It's a lot for patients and families, but it sounds like you guys have figured out really how to do an excellent job of educating all of them. And like you said, finding out ahead of time, are they going to be able to follow through with all of the precautions and things that need to be done to help their loved one, family member have a good outcome with their treatment.
We also go ahead and tell them, like, specifically about their treatment. For instance, the Lutathera, the lutetium-177, we give them some facts about it. For instance, 50% of the radiation that we gave in that one injection is excreted within the first 6 hours. So again, just to give them some context to the precautions that we're asking them to do, you're going to be with us when you excrete this 50% of it. So again, just giving them these little tidbits of, yep, you know what, it's 50% gone when you leave us. So we still want you to follow the precautions, but we don't want them to worry about being around people, about their caregivers. We just want them to go ahead and use standard precautions. You know, I'm going to handle my own excretions, and I'm going to be careful around the bathroom and that kind of thing.
That's great. I think that is what a great point to be able to tell them, so that probably will help decrease, any anxiety or worries that both the patient has towards, am I going to harm my family, or is this going to be harmful to them or to the caregiver, in knowing that information as well. Can you speak to the importance of multidisciplinary collaboration when treating patients with radioactive targeted therapies?
Yeah, so when we started doing all of the different ones that I mentioned in the podcast, the webinar back in February, I took a good look at truly everybody that I had touched during all of the creation of the education, and for nursing, for the staff, for everyone. And I thought, wow, it truly was a multidisciplinary collaboration. It's got to be, because you need everybody on board. This patient's going to be seeing a lot of different people, and we all have to be saying the same thing. So the care of this patient, if you follow them from when they're seen initially in the clinic all the way through the therapy, they're going to see medical oncology. If they are thyroid cancer or the neuroendocrine tumors, they will see endocrine. Of course, they're going to see nursing. They will be touched by radiation safety, nuclear medicine, radiology, pharmacy, ancillary services like the IV team, if your facility has that. We went ahead and we actually made appointments for our patients with the IV team so we could get started with their therapy in a timely manner and not have to wait for that service. We worked a lot with the patient education center, because they were making all of our pamphlets that we were giving the patients. We worked also with our outpatient chemotherapy unit, because, for instance, the Lutathera patients, they get a shot of samizdatin, octreotide, lanreotide, whatever they're on. They get a shot of that usually within 4 hours of being done with their Lutathera treatment. So we would send them over. We do send them over to the outpatient chemotherapy unit for that injection. So again, trying to put this all in perspective, all of these services had to have a piece of what we were doing and had to be collaborative and seamless for the patient. So we got them, all of the information they needed, and everybody knew the plan. So it's very important. It can't be done without it.
That's a big group, but you can see just from what you've been saying how each individual group or team really needs to come together to be able to treat these patients safely, effectively, and to get the best outcome for them.
Mm-hmm.
What are common misconceptions or assumptions about radioactive targeted therapy?
I think that the biggest one is that people, whether it's nursing, nuclear medicine, no matter where they're working, radiology, I think the biggest one is that the person who's caring for the patient feels that they may be harmed by doing that, by caring for that radioactive patient. And even when my area started doing all of these therapies, again, the nurses were voicing concerns. And how do we address those concerns? So we went out and we started talking about to everybody, radiation safety especially, and said, how can we make them feel more comfortable? Because we want them to know that we believe that they are safe. They won't be harmed taking care of these patients. So radiation safety made up a sheet for us and said, okay, what are some of the questions? And we had radiation with pregnancy. Does that affect the nurse? And they said, nope, actually to cause sterility or any kind of damage there, the dose has to exceed 400 rem, which is 400,000 millirem. And remember what I was saying about what the dose is, that if we see any exposure what we've seen, and it was 10 out of 400,000 millirounds. So when we put it into those kind of numbers and that perspective, we started seeing the staff be more comfortable. And pointing out the everyday radiation exposure that we had really opened eyes also. That was a huge misconception that we don't have daily radiation exposure. We do. A lot of our patients go for PET scans. And I said, radiation safety is telling us, hey, these patients come back and when you're in there taking care of them, you're getting exposed to radiation more than if you were taking care of one of our Lutathera patients. They're like, oh, gee, didn't realize that. We're like, it's a short exposure, but it's probably more.
There are definitely I'm sure, some very common misconceptions with, healthcare workers with these patients and these new therapies that are coming out. Mm-hmm. What are some other resources for nurses who want to learn more about this topic?
So the ONS website has several things that you can click into, whether it's on one of the ones that I've mentioned, like Xofigo, Lutathera, I-131. You can always go ahead and listen to the webinar. I think it's still available that I gave in February. And then, of course, the industry, whoever makes the drug that we're talking about, they have patient ed resources. So you can always go to their website and say, hey, I would like to know more about TheraSphere. What can you tell me about what it does and how it affects the patient themselves? And am I at risk being a family member and all of that? So if you want more resources, the industry, of course, loves to educate. Whether you're a provider, a nurse, whoever you are, they love to share their information and their studies.
Perfect. What's something about radioactive targeted therapies that isn't often discussed, but you wish more people knew about it?
So besides everything that I've mentioned when I've been talking about everything here, I went ahead and I asked our colleague in nuclear medicine who actually does most of the injections of our Lutathera patients. And she says, you know what, I want to answer your question. She says, I think something that people don't know, and I wish they did, is the logistics of that specific med and possibly others, depending on what you're giving. She said, for instance, Lutathera, she says, that is not a drug that's sitting on our shelf. It actually needs to be ordered in advance, and then there's a very small window of opportunity to use it. So it's not feasible to move a patient's treatment up a day or push it back a day because that drug often arrives to whatever institution's giving it. It arrives in the morning of that treatment. So like weather can be a problem. We've had occurrences where it didn't make it, the drug didn't make it through customs because some of lutetium, 177 in particular, Lutathera, some of it comes from Italy. So to get through customs and FDA approvals and et cetera, FDA has to go ahead and release the hold on it when it comes into the country. Again, it depends on where it comes from. Some of ours comes from New Jersey, but I know that we've had to actually do some service recovery because of this logistic problem that our nuke med tech was talking about. So we had to go ahead and give the patient and their family some tickets to go have some breakfast to kind of waste some time while we're waiting for the drug. Again, like I said, whatever your institution does for service recovery, it might be a free parking pass. So we've had to do some of that, and that's the logistical part that I think when she said it, I thought, you're absolutely right. I don't think that's something that a lot of people know. They might not know that drug comes from far away. It comes the morning that it's given. So it can be, several things can affect whether we get to give it to the patient.
I did not know that either.
Mm-hmm.
So that is really good information to know. And I'm sure, when the staff or the navigator, so many people, like we're saying, this multidisciplinary collaboration need to understand those pieces, even down to the delivery or where the drug is coming from, because there could be, that minute of an issue, or it could be a problem, like you were mentioning, having the patient move their treatment day. So how important it is that everybody understands the need to, once that appointment is made and the treatment is scheduled, that it needs to stay on track. So thank you for that.
Mm-hmm.
So as we wrap up today, do you have any final comments on nurses caring for patients currently receiving or who have recently undergone radioactive therapies?
Well, just two comments to wrap up everything I've said today and what I said back in February, and what I keep saying to the staff that I support on the unit that I work on, that these are safe to administer and safe to be around. We just have to know the precautions and be safe. We've got lots and lots of guidance. I mean, no matter where you work, I think that you have those people who guide you, whether it's nuclear medicine, radiation safety, patient safety officers. There's so many people that are going to make sure that what we're doing is safe. It's safe for the patient, it's safe for us, and it's safe to be around. And if it's not, for instance, if it's a higher dose of radiation, then those precautions are going to go into effect. You're going to be having that patient in a lead-lined room. You're going to be having limitations on how long you can be in that room. And you're going to be writing down on a log, okay, I got to be an hour in total in that room for my 8-hour shift. I'm done. So then the next patient or nurse has to take over. So as long as we stick to whatever precaution is created for our safety, we can best serve our patients.
Thank you so much, Pam. I think that this area is a newer treatment area for patients with a cancer diagnosis, and sometimes radiation therapies and radiation treatment, it's a smaller area in the whole oncology treatment area world. And so for you to be on here today and give some more information on this and really show some of the misconceptions and how the treatment is done, and really help to educate all of us and all healthcare workers out there with these patients that are receiving these treatments. It's been extremely helpful today. So thank you very much for being with us.
You're welcome. Thank you for asking.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.